Hello, this is Miss James. We're going to talk about Chapter 21 because I want to have time for some activities. So, we're recording this lecture. Your objectives. Please know your terms. That's the way that you will understand the chapter when you read it. And yes, you do need to read the chapters. You can't go just by what I talk about in PowerPoint. You can look at these YouTubes. They're important about dystocia and a few other things that I would like for you to watch. Dysfunctional labor or dystocia is abnormal, difficult labor. It's not just shoulder dystocia, which a lot of times you hear about shoulder dystocia, but you don't hear that dystocia is a problem with abnormal labor. And it can be caused by a lot of different factors, both maternal and fetal. And it happens whenever labor does not progress as it should. And it's slow, it's usually abnormal. Sometimes it ends up with an emergency C-section, sometimes it ends up with having to deliver by alternate means. There's a problem with effacement, dilation, or fetal descent, or all of the above. It could be the powers, the passenger, the passage, mama's psychological issues, or it could be a combination of all of them. Risk factors, epidural being one of them. As I've told you before, after she takes an epidural, sometimes it slows everything down. Or too much analgesia. Sometimes, if she's had too much for pain, it will slow the progress down. More than one gestation. Hydramnios, oligo, or polyhydramnios. She has just exhausted. She has pushed and pushed and pushed to the point that she is no longer effective anymore. Ineffective maternal pushing, just like I said, or if the baby is in occiput posterior position (OP), where the back of the head faces the mother's back. Early identification and interventions are essential to minimize the risk for both the mom and the fetus. This is why fetal monitoring is so important. Table 21.1 in your book. I'm trying to go along in your book to make sure that I give you reference to the right places. That's on page 730 and 731. Gives you a really good explanation of all the risk factors and the therapeutic management of each. Other risk factors that I wanted to make sure I mentioned to you, the first stage of labor is longer. She's short and she hasn't had a delivery yet. This is her first one. The fetal birth weight is over 8.8 pounds, so if it's a really large baby. If there is a shoulder dystocia, where the shoulder is the presenting part, any other abnormal fetal presentation or position, and any fetal anomalies. It the table in the book breaks everything down by problems with the powers, the passenger, in the presentation, as well as the passageway, and it's a very good table. So make sure you look over it and you read it, and it goes all the way to page 736. Risk factors for dystocia are mothers who are over 35. If she has a high caffeine intake, if she's obese, if she's a gestational age over 41 weeks, because the placenta is getting to the point where it's no longer functional, and so everything is slower. If there's a chorioamnionitis, that is an inflammation or an infection of the lining of the amnio sac. Ineffective uterine contractions, or if the fetal station is very high but she still has cervical dilation that is complete. This is a photo of the Mac Roberts maneuver whenever there is a shoulder dystocia. Um, it's where the healthcare provider is at the delivery side. The nurse is helping by pulling mom's legs back and putting pressure down onto the lower uterine segment, and you can see why the bladder would definitely need to be emptied, and plus run the risk of causing damage to the brachial plexus of the baby or breaking a bone. But when the baby is already engaged and the shoulder is hung, and she's going to deliver vaginally, this is the procedure that we would institute. Causes. In that table in your book, there's no need for me to read over all of this because it's all in your book and it gives you a really good, clear explanation. I also put you a good handout that's in Moodle to help you. True or false? Psychological stress in the woman can contribute to dystocia. Well, we all know that is true because we have talked about psychological issues, problems, pressures, um, a poor support system, emotions like fear and anxiety. She's helpless. She might be alone, or she just may be very, very tired. All of these things can cause problems and contribute to dystocia. Assessment and management. Always get a really good assessment. History of risk factors. What is her frame of mind? Baseline vitals. We need to monitor contractions and see how effective they are compared to the fetal heart rate and the positioning of the fetus. Management is also in Table 21.1, so I will let you read over all of that. Preterm labor. Labor that occurs before it should. It's page 741 in your book. The occurrence of regular contractions accompanied by cervical effacement and dilation before the end of the 37-week gestational mark. Viability, as we've talked about before, is 20 weeks. This is the most common obstetric complication, is labor that begins before it should. However, it's the biggest contributor to fetal morbidity and mortality. It has a profound effect on the survival and the health of the newborn if they're born too early. So, therapeutic management is to do a risk prediction. Page 741, it goes through the drugs that we can give and to determine who is at risk for preterm birth. We don't really know what the cause is, but we do want to try to prevent even something that we feel is as simple as a urinary tract infection. We want to treat it ahead of time, and we want to make sure she doesn't go into preterm labor. Medications are also listed on page 742 and 753. We want to find out if she's having any type of pelvic pressure, if there's a change in the discharge, if she's having low or dull backache, any type of cramping, any kind of GI upset, a heaviness in the thighs, contractions that she can tell she's having contractions with or without pain, if she's having more contractions, more than 6 in an hour. Um, Sometimes she's not even aware that this is happening. So it's very important that we educate very, very well and ask her every time she comes in of any of these problems or risk factors. Tocolytic drugs, those are the drugs that will help to stop contractions. There's no clear first line, but tocolytics may help to prolong the pregnancy for 2 to 7 days, and then we would also give her steroids to help with fetal lung maturity, just in case she's going to go ahead and deliver. If she has group beta strep, which sometimes is common with women who are pregnant, it is not a STD, it's just a bacteria. We would give her antibiotic prophylaxis. Now, that page number is incorrect. The risk factors are on, let me see. That's from the old book. If any of you are using the old book, the new book, you would want to look at box 21.2 on page 744, and it gives you a very good listing of all the risk factors with preterm birth. Some are the same as they are for dystocia. Some of these can be very subtle, like I told you, and the contraction pattern is very important. We would do a CBC, a urinalysis, often an amniotic fluid analysis, a fetal fibronectin. For that particular test, she will have not needed to have sex within the last 24 hours so that we can get a accurate reading. A cervical length via transvaginal ultrasound. We may do a salivary estrogen level, and she may need home uterine activity monitoring if she's threatening. Uh, if she lives too far away from the hospital, we will probably admit her and monitor her in the labor room, sometimes as long as we've kept them in there. Signs and symptoms: contractions that may or may not be painful. She may feel cramping, feel like the baby is just balling up on the inside, pain or discomfort or pressure in the vulva area or the thighs, change or increase in discharge, pelvic pressure like the baby's pushing down, abdominal cramps. Sometimes she'll have with diarrhea, sometimes without, or she'll just feel bad, like something's just not right. So we want to stop preterm labor before she reaches 3 centimeters. We want to treat infections, especially UTIs. Broad spectrum antibiotics are usually best. Limit activities, left side is good. She needs to keep hydrated. And the tocolytic drugs that we were talking about in the other drugs would be on page 742 and 743. Please take note, some of these, these drugs are used for other things besides preterm labor. So take a look at all the other uses they have. This is on page 742 and 743 of your book. And these are the ones that are more common that we use now to help with contractions. Sometimes we'll give breathine as well, but it's not for long term. Beta adrenergics like Ritodrine, Utapar, Breathine, Terbutaline, that's used often. Magnesium sulfate, the other ones that I just went over with you on page 742 and 743. Your new textbook, for some reason, does not include breathing, and it is one of the ones that is used quite often. Know what the maternal and fetal side effects are of these drugs and know when these drugs are not indicated. So that's on page 742, 743. And because not only for your exam, but if you were working in the labor room, you would need to know when these things were indicated. On page 746 of your book, it does talk about terbutaline, um, and it has specifics of why it is given and why it is not given. And on page 745, it talks more about tocolytic therapy and when medications should and should not be given. Teaching patient how to prevent preterm labor is on page 746, Teaching Guidelines 21.1. So take a look at that too. Accelerating fetal lung maturity, we would do this with administering corticosteroids to the mom, betamethasone or dexamethasone. Both of these are given IM, and usually we can give this between 24 to 34 weeks to promote lung maturity for the fetus. Usually, if we're giving her celestone or betamethasone, it's 2 doses IM 24 hours apart. And we need to make sure if mom has infection or any kind of pulmonary edema, we need to monitor for signs of infection because we all know corticosteroids affect the immunity of mom. Education, 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 and definitely psychological support for the mother because she's risking delivering a preterm infant, and that is very anxiety provoking, makes her very fearful. All right, late, delivering late after 42 weeks gestation. We don't know why this happens either. Sometimes it's often because mother's older, um, but it's dangerous because it extends past 42 weeks, and sometimes incorrect dates are the reason for this. But it can be an unsafe situation for both mom and the baby because the placenta after 40 weeks begins to no longer be as effective as it was. And maternal risk is related to a large size of the fetus. It increases the chance of a cesarean. It might also include dystocia or birth trauma or even hemorrhage and infection. The fetal risk or macrosomia means the baby has a large head, shoulder dystocia, which would possibly lead to a brachial plexus injury. The APGAR scores could be low, or a post-maturity syndrome, which is a lack of subcu fat and muscle, or the risk of meconium staining because the baby begins to be distressed, and also cephalopelvic disproportion because the baby has gotten bigger and unable to be delivered vaginally. So all of this predisposes the baby to being delivered by C-section or experiencing birth trauma by being delivered vaginally. There is a risk for a higher mortality rate for babies who were born after 42 weeks. Amniotic fluid volume declines after 40 weeks. The placenta is no longer as effective. So this would lead to fetal hypoxia, an increased risk of cord compression, and the cushioning effect is lessening whenever there's less amniotic fluid. So the baby would run the risk of going into distress, passing meconium, and having a meconium aspiration. So here again, we need a good thorough history, good prenatal care. Asking the mom to let us know when she last felt the baby move. Sometimes we're needing to do non-stress tests more frequently if she's threatening going longer than she needs to go. And we need to make sure she has a good understanding of what to expect. Okay, you can read this case study and work through it on your own. And like we said, sometimes the estimation of the date of birth is incorrect. So we need accurate dates, daily fetal counts, sometimes a non-stress test twice a week. The physician may want to do amniotic fluid analysis. Cervical exams would be done weekly, and we would make sure the client is understanding what's going on and try to help her with her coping ability. So it's important for us to conduct fetal surveillance. There would be a decision if she's not going into labor to induce labor with Pitocin or other drugs that are for labor induction. Give her a lot of support and education, and of course take really good care of her during the interpartal period. We don't want to forget about the partner during this time as well. Intrauterine fetal demise, we will talk more about this during perinatal loss, but intrauterine fetal demise, there are a lot of causes. It's very devastating. Sometimes we just don't know why this happens. You're not going to find a whole lot in your book about fetal demise. That's why I talk about it a little bit here. It's very devastating to not only the family, but also the staff that helps to take care of this family, because what is the most devastating is whenever this happens and she's at term. So we really want to make sure that we take care of this very carefully. And in 756 of your book, it talks about intrauterine fetal demise. She's still going to grieve, and we've got to allow her to do this. But as I was saying, the most difficult time is whenever the baby is at term and something has happened and it dies in utero, and mother has to deliver a baby that is no longer living. Our assessment is we're unable to obtain fetal heart tones, but an ultrasound must be done to confirm that there is absence of fetal activity. We do have to do a labor induction where we give Pitocin to induce labor for her to deliver. The reason for this is we're not wanting to put mother at any further risk of a surgery. And then she's always going to have to look at that scar and remember she had this surgery and came home without a baby. So it's easier on her psychologically, plus we're not putting her at risk. We need to assist her with the grieving process, and of course, usually put her in contact with the social services department because they have good resources that can help with the grieving process even after she goes home. This is a very difficult time. It can be due to a number of conditions: a prolonged pregnancy, an infection, mother has hypertension or advanced maternal age. There is an ABO incompatibility issue. the rupture of a uterus, diabetes, congenital anomalies, a cord accident, an abruption of the placenta, trauma, or premature rupture of membranes, or a hemorrhage, but sometimes there's just no explanation. And it's trauma in pregnancy, car accidents, domestic violence is still one of the highest contributors to maternal and fetal morbidity. Um, and you can imagine all the issues that go along with trauma. Umbilical cord prolapse is an obstetric emergency. This is whenever partial or total occlusion of the cord happens with rapid fetal deterioration. Sometimes you will see the cord, and sometimes it will not be where you can see it, but you can tell from the fetal monitor that there is some type of cord compression because there is rapid deterioration of the baby. The nursing part for us is that we prevent the risk factors with continued assessment of the client and the fetus, and we need to recognize this promptly. Um, this would be on page 758 of your book, and there's a couple of pictures at the bottom that help you see what a cord prolapse is. There's one within the uterus or one that the cord is visible. Sometimes this occurs whenever there is an abrupt rupture of the membranes and the cord falls through. It is common sometimes whenever the baby's in a breech position, and it's the risk whenever the presenting part does not fill the lower uterine segment. It usually will lead to total or partial occlusion of the cord, but this is the only lifeline the fetus has, so it's important for us to find a way to get the baby off of that cord. Prevention is the key. We want to assess her risk factors, and we want to be aware that usually this is from a malpresentation, a growth restriction, a premature or ruptured membranes when a fetus is in high station, whenever she has hydramnios, whenever she has had multiple pregnancies, or she is having more than one baby. We want to make sure if we're going to have to artificially rupture mom's membranes that she has IV in place, because we do not want to be caught with a prolapse cord having to run her to surgery to get the baby delivered with no IV. So if a physician is saying we're going to rupture her membranes, make sure you have an IV. We want to make sure that we verify where the presenting part is and that the baby is engaged into the birth canal. If it's not, whenever we break the membranes, we need to make sure that we're not feeling a cord. If we do feel a cord whenever we do a sterile vag exam, you cannot move your hand. You need to keep the baby's head off of the cord until the mom is rolled into the OR to deliver the baby by cesarean. Always, always, the vag exams must be sterile. If we can't feel a cord, but we can tell there is cord compression, changing mom's position to a Sims or Trendelenburg or a knee chest helps to relieve cord pressure, and we still monitor the fetal heart rate. If it's not getting any better, then we put her on oxygen and we call the physician, and we want to prepare for an emergency C-section. We want to make sure to relieve the pressure, try different positions, and she needs oxygen. We could get oxygen on her 10 liters per mask while someone else is calling the physician. And this is just a picture of the different positions you could put her in to relieve the pressure on the cord. The picture on the top right is whenever you perform a sterile vag exam, you feel a cord, you keep your hand there to keep the head off of the cord until you can get to the OR. And this is whenever the nurse gets to ride on the stretcher with the patient with her hand inside, keeping the baby off the cord. Placental abruption is an obstetric emergency, and it is on page 759 in your book. It's painful bleeding. It's whenever she has heavy, heavy bleeding with pain because it's a premature separation of the placenta from the wall of the uterus. It can be deadly for both mom and baby. The risk factors are preeclampsia, gestational hypertension, seizures, rupture of the uterus, trauma, smoking, use of cocaine, coagulation defects, previous history of abruption, domestic violence, and placental pathology. These may force blood into the underlayer of the placenta and it causes it to detach. These risk factors are on 759. Some of these other page numbers are from your old book, those of you who have the old one. The management depends on how old the fetus is, how bad the hemorrhage is, and the maternal fetal oxygenation. It's most always a emergency. You want to maintain mother's cardiovascular status because if we do not, we're going to lose the fetus and we need to deliver the fetus promptly. Cesarean birth if the fetus is still alive, but if the fetus is not, it's usually by vaginal birth. But please note, realistically, um, usually mom is hemorrhaging if this is happening, and usually there's going to be a cesarean because there's some other surgical things that may have to be involved if she is continuing to hemorrhage. Everyone has to move very quickly because this can be a death situation for both mom and baby if you don't move quickly. But the thing to remember is it is painful bleeding. Uterine rupture is also an obstetric emergency on page 759 of your book. Usually we notice this by marked sudden fetal bradycardia. There is a sudden fetal distress because the uterus has literally torn, it has ruptured. It's catastrophic. Most times you have a sudden fetal bradycardia, and most times it is a significant fetal morbidity risk because there is such hemorrhage, there is loss of oxygen to the baby. It's going to have to be an emergency cesarean and most definitely continuous monitoring of the mom and the baby. We need to know what the risk factors are, especially if she is a previous C-section, a classical incision. She is at risk for uterine rupture if she goes into labor, and so we need to know that and we need to prevent that. If she's had a prior uterine rupture, any type of trauma, any type of previous molar pregnancy, which is a tumor, any history of placental abnormal implantation of the placenta, malpresentation of the baby, if we have done a labor induction with using too much Pitocin, she runs the risk of a uterine rupture. And if she has smoked crack or cocaine, she's at risk. This is usually, like I said, sudden fetal distress, sudden fetal bradycardia, and it is an emergency. We have to do something very quickly. Abdominal pain and tenderness. She'll have chest pain up between the scapula. She'll go into hypovolemic shock. You will see fetal distress or no fetal heart tones. The contractions will cease, and you can actually feel the fetus outside of the uterus. This is a picture of a torn uterus, and you can actually feel the appendages of the baby outside of it. Uterine rupture, we've got to stabilize the mom first. If we don't have a stable mom, we won't have a stable baby. It's an emergency cesarean. She's going to have to be managed for shock. So it's very important that we recognize women who are at risk for a rupture so that we can do what we can to prevent, because it is life threatening. We need to be very careful whenever we're administering Pitocin. We're the ones monitoring the mother, we're the ones seeing the strips, and we're the ones that are held responsible if we see that something is happening. It is okay to not turn the Pitocin up if the baby is not tolerating it. It is okay to turn it off if we feel we are in a emergency situation and the baby needs some rest. Watch for signs and symptoms of shock and hemorrhage. Amniotic fluid embolism is rare, but it does occur. This is an embolism from amniotic fluid that has particles and things in it, because you know the baby's waste is floating around in the fluid and it gets into the lungs. It is another emergency. She will have a sudden onset of decreased blood pressure, difficulty breathing. She may begin to start having some clots in the bloodstream due to a breakage in the barrier between the mom's circulation and the amniotic fluid. So she will be acting as if she has thrown a blood clot. So and it's hard to tell the difference because they have the same symptoms. They have trouble breathing, their blood pressure drops, they get turn blue, they may have seizures, heart rate will go up. She starts to have coagulation failure. She may be having some blood clotting issues here, but hemorrhaging here. She may go into disseminated intravascular coagulation, which you'll learn a whole lot about that in MedSurg 2 and 3. She can develop pulmonary edema. Uterine atony is whenever the uterus is just not, it's like a muscle that's just worn out with hemorrhage. She may develop adult respiratory distress syndrome, and she can go into cardiac arrest. So our management is very supportive. We want to maintain oxygenation, her hemodynamic function. This is critical care monitoring. We're turning into an ICU in the labor room until she can become stabilized. And you can read about it on page 760 of your book. It is rare, but it is something that happens, and we have to monitor her very, very carefully. She feels very agitated. She goes into respiratory distress very quickly. Heart failure. It's like a domino effect. It one thing leads to another, leads to another. If she survives, sometimes she is having she does have neuro deficits. Excuse me. Okay, I apologize for that. But as I was saying, it's just a domino effect, and if we are able to stabilize the mom, often there are major neuro deficits because there has been a lack of oxygen, or she has had a lot of circulatory issues that were just difficult because, as I said, if she gets into DIC, she's bleeding from every orifice, and she's having lots of problems that are very difficult to manage. And if she is still pregnant and the fetus is there, often the fetus does not survive as well. So, this is another part of your case study to be able to discuss the risk of a prolonged pregnancy from your case study client. the risk to her unborn baby for prolonged pregnancy and nursing care that is required for prolonged pregnancies. Induction and augmentation. I'll spend a little time here because often this is an area where students often get confused on what an induction is and what an augmentation is. Induction means we're going to stimulate contractions using either medical or surgical means. This is whenever she's not having contractions that are effective enough. Uh, she's not having contractions at all. Augmentation is she's having contractions, but they aren't effective to cause dilation and effacement. So we augment that with medication to help move the labor along. The reasons for this is often a prolonged gestation, prolonged premature rupture of the membranes because she's at risk for infection. She has gestational hypertension, which she needs to go ahead and deliver the baby to relieve that. She may have cardiac disease, renal disease, a chorioamnionitis, a dystocia, a fetal demise, isoimmunization that was with the ABO incompatibility, or diabetes. Those are the reasons that we for it. Now, sometimes there is an induction because mother requests to go ahead and deliver, but that is not what we're talking about here. Um, Both hospitals have the 39-week rule, which is no um, inductions before 39 weeks to hopefully have good lung maturity. Um, Induction and augmentation is on 749 in your book. Fetal maturity must be acknowledged, and it must be measured before induction. This is what should be done. Table 21.2 talks about vaginal exams and Bishop scoring, and this is what is supposed to be done to see if the cervix is favorable for an induction. Do you see this very often in the hospitals today? No, you do not, but this is what is supposed to be done by the physician to determine and to assess if the cervix is favorable for a labor induction. And that is supposed to be documented in the chart before those medications are started. We need to, for cervical ripening, the Bishop score must be at least at one of the hospitals, if it's at least a 5. Um, and this is a partial Bishop score that you will see in the book, but the doctor is the responsible person. Some people will use herbal agents, castor oils. Some of these are old wives' tales. Sexual intercourse or breast stimulation, that does not need to be done. Mechanical methods and surgical methods are ones that we'll use. Pharmacologic agents and oxytocin. You can read about those on page 751 in the drug guide. Know what the differences are, especially between Cytotec, Donnaprostone, and Pitocin. What's the difference? The Cervidil and the Perpidil. What's that used for? What is the Cytotec used for? Um, and what's the oxytocin used for? Um, the Bishop score is most commonly used. It should be used. Herbal agents you have to be careful with: castor oil and enemas, sexual intercourse, breast stimulation. I've told you what's happened with that before. So Inductions are more safely done with medications. Um, we need to know what the gestational age is. We need to know the fetal status, the maternal status, and the Bishop score. Explanations are in your teaching guidelines for 21.2 to make sure the patient is making an informed decision. Oxytocin administration is on page 753 on the importance of once we start the oxytocin, we need to have a good baseline set of vital signs. When it starts, we monitor the fetal heart rate for at least 15 minutes, and then we have to evaluate the contractions and resting tone every so often after that. And each time we change the rate is supposed to be done again every 15 minutes during the active phase and every 5 minutes until delivery. I and O is very important because sometimes with oxytocin, she will have some increased fluid retention. If she has a cardiac problem, sometimes this will increase to have a cardiomyopathy, but we'll talk more about that later in the semester. She's got to have some pain relief and support or help her to use pain relief techniques because with Pitocin, her labor pains are a little bit more extensive than they are by just regular labor pains. Oxytocin is an important agent to ripen the cervix. Yes or no? You need to know the answer to that question. Is to induce or augment once the cervix is ripe. There are cervical ripening agents that we can give her prior to beginning the induction or the augmentation, and you need to read about those. Amnio infusion. This is sometimes if there is cord compression and we want to put a little more fluid into the amniotic sac to help get the baby's head off of the cord. If there's not enough of amniotic fluid because of placental insufficiency, if the baby is post-mature and we're needing to get a little more fluid inside, or if there's been a rupture of the membranes, preterm labor with premature rupture, or if there's thick meconium fluid and we're wanting to do an amnio infusion to wash some of that out so there won't be a meconium aspiration. We need to do a lot of teaching. We need to do good assessment and prepare mom for potential cesarean birth. And this is on 761 in your book. We have to follow hospital policy for these amnio infusions because different hospitals have different indications of why it's done and how it's going to be done. And this is done with the use of an intrauterine pressure catheter so that we can hook up warm IV fluids to it. And usually it's running the fluid, if it's for meconium, we're usually running the fluid in and running it right back out to flush. Contraindications are vaginal bleeding, umbilical cord prolapse, if there is an infection, if the uterus is contracting a lot, and if there's severe fetal distress, we would not want to add any distress to it. Please note, the mother has to be dilated at least 2 centimeters to be able to use an internal intrauterine pressure catheter. If she's not dilated, we won't be able to get it in. An amnio infusion is appropriate for a pregnant woman experiencing a prolonged second stage of labor. Yes or no? No. It's for severe variable decels because of cord compression, oligo, due to placental insufficiency, post-maturity, or rupture of membranes, premature labor, premature rupture of membranes, or thick meconium fluid. All right, now we're going to talk about assisted birth a little bit. If the baby is, we're having difficulty with the baby being delivered vaginally on page 762. Forceps or vacuum extractors. This is whenever we apply traction to the fetal head for prolonged second stage of labor and we have a non reassuring fetal heart rate, a failure of the presenting part to fully rotate and descend, limited sensation or inability to push effectively. There is a fetal jeopardy or fetal distress. We have maternal heart disease and we don't want her to be pushing, acute pulmonary edema, an infection, maternal fatigue. There is a risk of trauma to the mom and the newborn, and we want to prevent this to reduce the uh, the trauma from using these techniques. Um, Prevention is allowing mom to be in an anatomically correct position while she's pushing, if we can. Frequently changing her position, letting her get up and ambulate if it's permitted, reminding her to keep her bladder empty so there's plenty of space for the baby to move down, and providing adequate hydration. We have to continue to assess her vital signs, contraction patterns, how the fetus is doing, and mom's maternal response. Um, the vacuum extractor is only indicated for vaginal birth. It is never supposed to be used for a cesarean section. The forceps look like just two long blades that are inserted to help pull the baby's head down. You see a picture of it on page 72, and here's another page right here. Sometimes the baby's head will have some forceps marks on it. Um, there's a lot of damage that can be done here if the physician does not know how to use forceps correctly. The vacuum extractor is just that. It's a little cup placed on the baby's head. It's a suction cup, and suction is placed on the baby's head during the second stage of labor to help get the baby to come down. But if that cup pops off 3 times, the physician is going to have to do something else. Um, Cesarean birth, the two common incisions are the classic or low transverse incision, and you can see that on page 763 of your book, um, the low transverse. That is the one that is the most common, but realizing this is a major surgical procedure, and major surgical procedures do come with risks. So a good history of physical, maternal, and fetal indications, and it's the same preoperative and postoperative care that we would give any other surgical patient, except with mom, we're wanting to make sure the fundus is clamping down as it should. Mom still has the same risk of complications from surgery, infection, hemorrhage, aspiration, pulmonary embolism, a urinary tract trauma, thrombophlebitis, paralytic ileus, and atelectasis. So we still do all of our post-op turn, cough, deep breathe, and all of those things that we do for our regular um, patient. Transient tachypnea of the newborn may also happen because the baby has not been allowed to go through the normal birth process of squeezing the fluids out of the chest, and so sometimes they have a difficult time transitioning because they haven't been able to pass the fluids normally as they would from a vaginal birth. Vaginal birth after C-section, this is still controversial because the client is at risk for a uterine rupture and hemorrhage because she's delivering a baby uh, from after a section, and that uterus has already been cut. So it is very important that the patient have very good information, and this you'll find on page 755 of your book. There's a really good checklist put out by the American Women's Health and Neonate Association that mothers should be informed and sign a consent that she knows the risks. If she is a classic cesarean, she should never be attempting a vaginal birth after cesarean. There are contraindications, uterine rupture being the main one. She has to be kept on a monitor. We have to have all the surgical crew in house ready for an emergency at all times, because if she ruptures, we have to be ready to go ahead and deliver the baby by section quickly. The nurse is the advocate for the client. So the nurse has to have expertise in reading the fetal monitoring tracing so that we are able to see a non reassuring pattern quickly and institute emergency delivery as soon as possible. The physician has to be close by and in the house as well to deliver this baby. This can be offered, but this is one of those things where mom needs to have a very fully informed consent so that she understands the risks, even with just a trial labor. I'll share one happening that I encountered. Mother was going along fine, wasn't having any pain, everything was great. All of a sudden, we lose the tracing. She has had a major uterine rupture, and she is just she's devastated. The baby was fine, had a few little learning deficits, but she had no pain, and just all of a sudden her uterus ruptures. She doesn't have pain. We lose the tracing. That's the only way we knew how the baby was decompensating. So this is it for this chapter. If you have any questions, please let me know.